And welcome back. We will continue on with our agenda. I think we all felt invigorated and motivated by the previous panel and wish we had more time. I always leave this meeting feeling as though I wish I had more time. But I will turn over the next portion of our agenda to our wonderful PACHA members and subcommittee co-chair leads, Jen Cates. As many of you know, has been a longtime expert in the global space and co-chairs our global subcommittee. And so her, along with Jesse Mylan, who co-chairs our newly formed Aging and HIV Long-Term and Lifetime Survivors subcommittee, will co-chair this next panel. So I will turn the floor over to them. Thank you.
Thank you so much. I'm hoping that this doesn't take the mood down from where we were, but there's always hope. So we will end with hopefully a hopeful note. So Jesse and I and some others, we really wanted to put this session together here at PACHA on what's happening across the country and around the world, pushing back against LGBTQ rights and access to healthcare and policy, because we're in a very complicated period. And also it's Pride Month, but really because on a more serious note, it's a very complicated period. There's many reasons why I think it's complicated, but just some interesting statistics. There are more, on the one hand, there are more people identifying as LGBTQ than ever before in this country, particularly young people. The share of all people in the country, adults, it's about 7% of the US population. Of young people, of Gen Z, it's over 20%. And that's just going to increase. There's also, the highest ever levels support for same-sex marriage, about 70% of the public. So that's we've seen that trend over time. Yet at the same time, there's been this recent and very fast rise, and you'll hear this from our panelists, in laws criminalizing same-sex behavior, LGBTQ identities, access to evidence-based care and needed health services in the US and around the world. And in the US, it's particularly targeting young people, but not only, but it's been very, very fast. Currently in the US, for example, as you'll see, I think in the visuals, half of all states restrict and in many cases criminalize access to gender-affirming care in some fashion for young people. Globally, more than 60 countries have national laws criminalizing same-sex behavior or relationships, including recent what's happened in Uganda, a law that was passed and was upheld by its constitutional court. So there's this these two things happening at the same time. And as you also hear, there's a growing body of research that it's been building that shows that these laws and policies have negative and adverse health effects and HIV and contribute to HIV risk. So there are real health consequences and they affect real people's lives. For all of us working in public health and working to promote evidence-based health policies and programs, it really affects our progress. So we wanted to provide an opportunity for PACHA to hear from experts about these challenges to help inform our work, the implications for progress of the National HIV/AIDS strategy, and more broadly, progress towards global 2030 HIV goals and beyond. We've assembled a panel of experts whose research and lived experience can provide the latest data and information on what is happening here and around the world. We hope this will inspire us and give us insight into what we might be able to take from it, again, as PACHA in our purview. I'm just going to list who's here, but we're going to introduce them a little bit more specifically when we get to, we have we've divided into domestic and global, but that's just really for ease of presenting the content. I think the sort of commonalities across both are very evident. The panelists that we have will be Rodrigo Hang-Lettinen, Kellen Baker, Chris Byrer, and Michael Agadero. Aria Lester, who was supposed to be here, was unable to attend. So with that, I'm going to turn it over to Jesse Mylan, who will take it from here.
Great. Thank you so much, Jen. And Jen and I want to thank our co-chairs, our PACHA co-chairs, for recognizing the opportunity in Pride Month for us to speak specifically about the LGBTQ community. We always talk about it, of course, in PACHA meetings, but in Pride Month, it was important that we really have a strategic focus on what's happening globally and domestically with regard to LGBTQ rights. It's as though our lives weren't already bad enough with regard to stigma and discrimination, but now we have this proliferation of laws, both in legislative bodies and decisions by judicial bodies at both global and domestic arenas that are seriously impacting our lives. Yesterday, Rodrigo and I had the opportunity to speak before the Senate Democratic Steering Committee, which is all the Democratic members of the Senate, who meet every year in Pride Month with a few LGBTQ leaders. And we were two of the four who were there yesterday. And it was brought out that there's a perception that because of gay marriage or the same-sex marriage being made constitutional by our Supreme Court, that everything is done. But that is hardly the case. We knew that before, and even today, there are some 30 states that still do not have anti-discrimination laws that to protect people who are LGBTQ from discrimination in employment, in public accommodations, and in housing. That is a problem. We already know that most of those states are also the same states that have HIV criminalization laws. So our rights have not advanced as far as some people believe. And it's important that we understand that these new laws that are being proposed in states and in national governments in the global arena can have a serious impact on our own integrity, on our rights, on our sense of well-being, and of course on our access to healthcare and their impact potentially on ending this epidemic. So that's why we've convened this panel of experts to talk about the global arena and the domestic arena. And we're going to start with the domestic arena. And it's my great pleasure to introduce Rodrigo, who is the Executive Director of the National Center for Transgender Equity, and he will be followed by Kellen Baker from Whitman Walker's Institute, and they will give us a landscape of what's happening on the domestic side, and then Jen will introduce our panelists from the global side, and then we will open it up for questions and discussion from PACHA. And I want to be clear, we've also asked them to think critically about what PACHA might need to say to the Secretary that could help us with regard to making sure that these laws are not impeding our efforts to end this epidemic. So Rodrigo, please start.
Good morning. Thank you. Oh, amazing technology already up there. Thank you. Good morning. As Jesse said, my name is Rodrigo Hang-Leitonen, and I'm the Executive Director of the National Center for Transgender Equality. We're actually about to now be known as Advocates for Trans Equality. We are merging with another national transgender rights organization to launch a brand new entity with double the resources, double the influence, double the power. And thank you all so much for taking the time to be here today. We know you have lots of demands on your time. I really appreciate you joining us today. Now let's see if I can work this. Oh, there we go. It's a miracle already. Managed to advance the slide deck. We take victories where we can find them. So I'm here to give an overview of the dramatic increase the transgender community has been facing in legislative attacks. I'm not going to go too deep into the healthcare ones in particular because my colleague Kellen Baker will deep dive into that right after. But it's important to put this legislation in a historic or at least somewhat historical context, recent history. For many, many years, when tracking anti-LGBT legislation in state legislatures, we would hover at an average of about 40 bills, more or less, depending on the year. In the aughts and the teens, we were largely around 40, 50 anti-LGBT bills in state legislatures. To be clear, those are not bills that passed. These are just bills that were introduced. So it really ran the gamut of how many actually crossed the finish line. But think about 40 to 50, and then suddenly, see on this graph, it goes up like a hockey stick, which is the only time you'll hear me say a sports reference. But we go 2020, we go to 70 bills, which is already quite an increase. But keep in mind, 2020, many state legislatures actually shut down around March because of the COVID-19 pandemic starting. And if they continued to convene at all, it was largely only to address emergency legislation about that public health crisis. So think about 70, almost doubling the number of anti-LGBT bills we were fighting when the state legislatures were meeting for half of the amount of time. Then 2021 onwards, we get into literally hundreds of bills. So to the point that last year we were fighting 510 anti-LGBT bills. So from going to about 40 to over 500. That is a tsunami wave in a very, very short amount of time. Notably, most of that 510 last year were specifically anti-transgender. Most of those, the overwhelming majority, were not actually umbrella LGBTQ bills, or, to put in more technical terms, overarching sexual orientation and gender identity bills, but instead they were squarely about gender identity. They were squarely about transgender people. And many of those were actually even more specifically about transgender youth, squarely going after some of the most vulnerable people in our community. Certainly some of the most misunderstood people in our community from the point of view of everyday Americans who mostly are only starting to even understand what it means to be transgender. So all of this wave of this sudden increase in legislative attacks against transgender people is sending a chilling effect through the community. Now, what do I mean by these anti-transgender bills? You see here a breakdown that illustrates just how sweeping the topics are. It's these this anti-transgender or broadly LGBT legislation covers a gamut of topics. It's a whole variety, but you see the largest category are healthcare restrictions. Again, my colleague Kellen will expand more on what that means in greater detail. But healthcare restrictions are the most popular, dare I say. And then we have curriculum bills, which really is everything from book bans to eliminating or changing sex education in schools. There's also parental rights, sports bans and drag bans. You'll see here there's the category defining sex. This is an area that might seem esoteric, but is very important for transgender people's ability to live our daily lives. Defining sex bills are things that change the rules about what counts as male or female, or rather how you can update those boxes, male or female, or even the X gender marker on your IDs. So think about driver's licenses, state IDs, any kind of paperwork you would get from your local or state government. When a transgender person, when we can't update that little box, that MRF or X box, we are essentially outed as transgender every time we show our ID. And think about all the times in your life that you might show ID. You're definitely going to have to show ID when you're enrolling in a new job. And so, for example, we have heard horror stories of transgender people being offered a job. They start the paperwork process to then start, and suddenly that job offer evaporates again, because that's when the prospective employer found out that the person was trans. It had nothing to do with their resume or qualifications, but suddenly that job offer isn't there anymore. So we're often showing our IDs at really critical moments in our lives, applying for a mortgage, applying for a new apartment, enrolling our kids into school. So to be outed as transgender at these critical junctures opens trans people up to more rampant discrimination. So these bills, these defining sex bills, may not get a lot of attention from the media or even from the government, but they make a dramatic impact on people's lives. And although it may not seem obvious, federal government has a big role to play here. When state governments fail to make these documents accessible, the federal government can step up and at least improve those documents. So thankfully, the Biden administration and the State Department recently modernized the IDs policy for passports. We think of passports as usually for traveling overseas, but if you're transgender, that might actually be the only document you can get that accurately shows your gender, depending on what state you live in. And there's all sorts of opportunities for every government agency to modernize their own process for how they document gender and how people are able to update that. So I really encourage you, wherever you work, in whatever part of government you interface with at all, or even private entities or research groups, think about how are we tracking gender in our systems? And is there something we can do to make that more accessible? Here is a visual of the state bans on transition-related care. And again, I'm not going to expand on this, but just want to give you this visual of just how sweeping it is. At this point, much of our community now lives in one of these states where care has been undermined. And these attacks have a great impact on mental health. So we see that, so first of all, just concretely by the numbers, an estimated over 113,000, almost 114,000 youth, trans youth, now live in a state that has passed one of these bans. Now, keep in mind, almost all transgender youth live in a state where one of these bans was introduced. This is only the ones where those bills actually made it over the finish line. And research shows that simply being aware of, reading articles about, being exposed to this type of legislation increases the risk of depression, anxiety, and suicidality among transgender people, especially transgender youth. So again, think about how almost every state in the United States has introduced one of these bills, has debated one of these bills. And now think about if you are a 16-year-old transgender person learning about this, or you're struggling to come out, and this is your first exposure to transgender people in the news in the context of this kind of attack. What would the ramifications be on your mental health? There's also affecting families of transgender youth. It's not only trans people ourselves, it's the people who care about us and care for us. Several states have introduced legislation that, if passed, would have classified providing transition-related healthcare as child abuse. That, depending on the bill, affects either the parents or legal caretakers of these youth and or the medical providers themselves. And this has resulted in many transgender people and their families thinking about, do we have to move? Do we have to get out of here? Do we have to find a new place to live? And I have some data on that. This is from our latest survey, the 2022 US Transgender Survey. Shout out to Kellen, who's also part of the team on advising us on this. But at NCTE, we run this survey roughly every 5 years. It is the largest study of transgender Americans' experiences. And we found that 47% of transgender respondents considered moving to another state because of these bills. Almost half of all transgender people earnestly considered, weighed the options of, do I have to move because of this legislation that's being introduced that attacks me and my family? And this is, as I mentioned, the largest study of transgender people's experiences. We had over 93,000 respondents. When you think about how many transgender people there are, frankly, there's not that many of us, right? We're a small population. We're maybe 1% of the general population. To get 93,000 respondents was remarkable. From all 50 states, from all the US territories, and from military bases, transgender people serving overseas in the military, active duty today. So this is really an extraordinary finding to then have 47%, almost half of all trans people who responded saying they considered moving. Yeah, and 5% have already moved. 5% have already taken the drastic measures of packing up their bags and finding an entirely new place to live. This is crossing state lines. You can think about what upheaval happens in your life when you have to move like that. You often have to find a new job. If you have kids, you have to enroll them in new schools. You have to find new medical providers. So there's great risk of interruption of healthcare for transgender patients because so many transgender people are having to move to a new place, change insurance, find new doctors, and people are having lapses in their prescriptions, all sorts of interruptions in their healthcare. And be mindful that this is healthcare that may or being interrupted, that may or may not have to do with them being trans. So yes, it may be interrupting, for example, their access to hormones that's prescribed by a doctor, but it also might be interrupting their asthma medication. Just because you're transgender doesn't mean you can't get the flu or need a vaccine, right? You have all the everyday medical needs as well. And that care gets interrupted when you can't stay where you live or stay seeing your doctor. Here you see the breakdown of the top 10 states from which people have fled. So this is according to our survey respondents, where did they move out of? Of that 5% who had already moved, where did they move out of? Not a coincidence. that this list of states correlates pretty squarely to the states that had the highest number of anti-transgender bills introduced in their state legislative cycles recently, and or had very high media flashpoints of anti-transgender attacks and very public policy disputes over transgender rights. So for example, Virginia infamously had a number of school board races that got particularly nasty, where outright anti-transgender rhetoric was on the public stage for weeks and weeks and weeks. So you see them here. Now that resulted in, one can infer, in one of the top states from which people felt like they had to flee. There are also geographic barriers beyond this. So transgender people in rural areas have less access to culturally competent and affirming providers. We all already know that if you live in a rural area, there's a lower number of providers. That's not shocking. If you think about them being transgender and it's always, even in the best of circumstances, it can be hard to find a doctor who's going to treat you with respect as a transgender patient and is going to be informed about your care. So if you think about that combination of being in a rural area where there's less providers to begin with and being transgender, there's a lot of barriers here. There's a real scarcity. Many transgender people in rural areas travel an average of an hour and a half to see a provider, hour and a half one way to see a provider. And again, this is any kind of provider, not just transition related care. This is your primary care physician. This is anything routine, traveling way out of the way just to find someone who you don't have to worry about being discriminated against for being transgender. Some other health disparities that we found from the US Transgender Survey. Here's one. Almost half, 48%, reported having at least one negative experience with provider because they were transgender. And that could be anything from being refused care by the doctor to the doctor refusing to use their chosen name, the name that they actually use every day because it's not the name on the ID, being sexually harassed or sexually assaulted by the medical provider, or being physically or verbally abused by the provider. That's almost half of transgender people having had at least one of these experiences. And 24% did not see a doctor when they needed to in the last year because of fear of mistreatment. If you think about that last slide, almost half of transgender people have had this terrible experience. It's not surprising that then a lot of trans people don't want to bother going to the doctor because of concern that this could happen to them. So almost 1 out of 4 people thinking, you know what, I am sick, I am injured, I do need care, but I'm not even going to try just because I'm transgender and I can't risk it. 34% of respondents were experiencing poverty. That is not necessarily per se a healthcare finding, but we all know that if you don't have this kind of money, then it's much harder to get care here in the United States. So this is also a big contributing factor to transgender people engaging in healthcare avoidance, avoiding going to the doctor because they can't afford it. And 30% had experienced homelessness in their lifetime. That is way out of proportion to the general population in the United States. 28% did not see a doctor when they needed to in the last year because of cost. So the earlier one I said of avoiding to go to the doctor in the last year, that was because of fear of mistreatment. But then there's additionally people who, even if they weren't worried about that, they still can't afford to go to the doctor. They're uninsured, underinsured, can't afford the process. And 26% had issues with their insurance provider denying coverage of routine and or transition related healthcare because they were trans. This shouldn't be happening anymore because thanks to the Affordable Care Act, but it is still happening. Certainly insurance coverage improved with the passage of the Affordable Care Act in a number of fronts, but for transgender people it improved because of Section 5067 that really codified a provider and either an insurance company can't deny someone just because of their gender identity. So this has improved over time, but is still an issue. I'm actually literally right now in the middle of fighting with my insurance provider to cover routine gynecological screening. And if I'm having problems, and I'm the executive director of the National Center for Transgender Equality, you can imagine the scope of this issue. See, oh, there we go. I think that is actually my last slide. So with that, oh, no, sorry. Oh, to end on a positive note, this is very, very significant, actually. So as much as trans people are undoubtedly facing so much discrimination and so much hardship, specifically in accessing healthcare, it is notable that trans people are still overall more satisfied in life for having transitioned and specifically for having access transition-related care. 94% of those surveyed reported being more satisfied with their lives after transitioning to live as their true gender. 94%. So think about those rates of poverty and of discrimination and fear of mistreatment, which is all real. And nevertheless, people are saying, but I am still better off for having come out. There is no replacement for that. And 98% of those who received transition-related care in the form of hormones said they were more satisfied with their life for having gone on hormone treatment. And that's a similar number for surgery. I don't have it on the slide, but it was also similarly 98% for people who had gone through transition-related surgery. They said they are more satisfied with life for having done it. And I think that's very encouraging. It is definitely something that we should continue to spread more awareness around. There is a stereotype that being transgender is all doom and gloom, but clearly that is not the case. And this also underscores just how important it is that patients be able to access transition-related care. There is no other procedure that has healthcare procedure that has this level of satisfaction. You know, people get knee replacement surgeries and regret it 1 out of 3 times. So to have 98% of patients saying my life is better for having gone on hormones or had surgery is really remarkable and shows the power of this service.
Thank you, Rodrigo. That was absolutely amazing, and all of the data was insightful for the work that we have to do. We'll turn now to Killen to continue to set the landscape for us on the domestic side, and then we'll change over to the global. So, Killen.
Thank you, Jesse, and thank you, Rodrigo, for taking us down, but then you bring us back up. So, and as somebody who had a hip replacement a couple of years ago, I can attest, gender affirming care, way better deal. I'm going to talk a little bit. As you heard, my name is Kellen Baker. I use he, him pronouns. I'm the executive director of Whitman Walker Institute. We are the research, policy, and education arm of Whitman Walker Health, which is a federally qualified health center here in Washington, D.C. that I imagine many folks are familiar with, and we had the opportunity to host many of you for a tour on Tuesday. I'm sorry I wasn't able to be there, but I'm very happy that we had a chance to talk a little bit about Whitman Walker then, and now to have the chance to talk with you about the health policy landscape for LGBTQI+ people. As you heard from Rigo, we are looking at an unprecedented wave of attacks on LGBTQI people broadly, and also specifically on transgender people. So this is just another look. I'm a runner. I don't do things that have, hockey sticks or whatever. So rather than showing your graph, Rigo, I focused on this other image that essentially shows the same picture, which is that over the last couple of years, we have seen an unprecedented scope of attacks on transgender people specifically, as well as on the LGBTQI+ community more broadly. When we zoom in specifically on healthcare bans, you can see in 2018, 2019, 2020, very, very low levels. These are bills that were introduced, not necessarily bills that have passed, but we are seeing an incredible wave of restrictions on best practice medical care for transgender people. This care is in the United States, as in countries around the world, provided in an individualized and age-appropriate way. It is provided by licensed clinicians under expert standards of care, such as those maintained by the Endocrine Society and the World Professional Association for Transgender Health. So these bans are a really unprecedented intrusion of the government between a healthcare provider and their patients, between parents and their kids, between families and their ability to make these really personal healthcare decisions. Oops. So that gets us to this landscape. About half of the states now have bans on best practice medical care for transgender people. And I will tell you, I transitioned 20 years ago in Moscow, Russia. And the fact that it is now harder for somebody in Moscow, Idaho, to access care than it was for me 20 years ago in Russia, which, by the way, is the only European country that has actually banned this care for transgender people. That indicates to me that there is something dreadfully, dreadfully wrong. The other thing I want us all to note is take a look at these orange states on this map. These are the states that have bans on best practice medical care for transgender people, with a particular focus on youth. If you look at the map of abortion bans, you will see that it is remarkably similar. If you look at a map of states with HIV criminalization laws, again, remarkably similar. And we could go on with a number of really important issues, such as diversity, equity, inclusion, and belonging programming, where there are attacks on affirmative action, for example, or the ability of entities like schools or employers to take into account historical and ongoing injustices related, for example, to structural racism. The laws that are attacking the ability of institutions to do those kinds of programs and to have those kinds of policies are, again, this very, very similar map. And I'm wearing a very firm C3 hat, but I will point out that if you look at the map of states where voter suppression efforts are most intense and disenfranchisement is happening on the basis of race, on the basis of geography, on the basis of language and other factors, you will see, again, this exact same map. And I want to call out the Women's Research Institute on HIV, which earlier this year had a convening where we talked about essentially this policy syndemic. And Kay, I know your office has talked about this as well, that this is the kind of syndemic that is incredibly dangerous for our communities. It is incredibly dangerous for our HIV prevention and treatment efforts, because these types of policies really do constrict people's ability not just to get healthcare, but to essentially live every facet of our everyday lives. With regard to some things that are not entirely terrible, since Rigo, you did the down and up, we're going to go a little bit up, which is looking at Medicaid coverage. This has not been as affected by some of these bans as we might have expected, although you can see here those states that have the little yellow indicator, those are the states that have bans on medical care for transgender youth. So how that interfaces with the Medicaid program and what federal law in particular means in this area is something that is a major topic, needs to be a major topic of discussion. So you can see, again, these states here in green. These are states that explicitly provide coverage of medical care for transgender people through their Medicaid programs. And then, unfortunately, you can still see the persistence of the types of restrictions that target not just transgender young people, but transgender Medicaid beneficiaries of all ages. There have been some very interesting court cases. I don't want to take us too far down the road of litigation, although there's a whole huge landscape out there that I'm happy to talk about if folks are interested. But we did, for example, just see a court decision out of the Fourth Circuit, which affirmed that West Virginia's transgender exclusion in its Medicaid program violated a number of federal laws. So that has a lot of implications for how we think about this landscape going forward. The other positive thing that's out there is shield laws. So this comes, a lot of the attacks on transgender people, I said unprecedented intrusion of the government between patients and providers and between people and their ability to make personal medical decisions. Unfortunately, it's not really that unprecedented if you look specifically at an example such as abortion. So a lot of the attacks on transgender people take a lot of leaps out of the anti-abortion playbook. When fighting back, we are seeing a lot of organizations, a lot of states recognizing some of those parallels and taking action to try to enshrine protections, not just for reproductive health care access, but for gender affirming care as well. So this is a map of the states that have these shield laws in place that, for example, direct a state not to use its resources, a state agency not to use its resources to prosecute a case against a provider for providing care, a patient for receiving care, or a parent or other family member for making it possible for a young person to receive care. We've seen these in action. The Texas Attorney General in particular has been very aggressive in going out of his jurisdiction and attempting to seek information from hospitals based in other states. So he went after Washington, for example, Seattle Children's Hospital in Washington, which said back, I don't think so. I don't know if you've noticed, I know they probably don't, teach too much geography these days in Texas schools. But you may have noticed that Seattle is not, in fact, in Texas. So we won't be responding to your accusation of liability for providing care to young people from Texas, but they also asserted their shield law. So this is a really interesting area of evolving law going forward. There has been quite a bit of activity at the level of the Biden-Harris administration. There's been so much talk about the states, obviously, because so much important policy for good and for challenging happens at the state level. But there is also quite a bit happening at the federal level. I'm not going to talk about Congress because honestly, don't even get me started. But let's focus on the folks who are doing some really amazing work in this area. Advancing access to care for transgender people, for LGBTQ plus people. There are a number of lawsuits and statements of interest that the U.S. Department of Justice has filed against transgender medical care bans in states across the country. They have also asked for the Supreme Court to hear one of the cases involving bans from Tennessee and Kentucky. Again, I'm happy to talk about the litigation landscape if helpful. There is now a final rule on Affordable Care Act Section 1557, which Rigo mentioned briefly. Section 1557, as you all know, is the core non-discrimination provision of the Affordable Care Act, prohibiting discrimination on the basis of race, color, national origin, age, disability, and sex. The Obama administration in 2016 released a final rule under Section 1557 that clarified that those sex protections include gender identity. The Trump administration rescinded that rule just 3 days before the Supreme Court ruled in Bostock versus Clayton County that sex non-discrimination protections do, in fact, include both gender identity and sexual orientation. So this final rule, which just came out in May of this year, restates that position, which makes it easier for transgender people, for LGBTQ plus people across the country to file complaints and to seek relief from discrimination such as that Rigo was describing, documented in the US Transgender Survey. HHS has also released a final rule on HIPAA protections. So of course, HIPAA applies broadly to all kinds of health data, but there are opportunities to enhance protections for specific types of data. And so again, this spring, HHS released a rule that tightens HIPAA privacy protections for data related to reproductive health care. So that provides an important framework for us to think about how do we protect data related to being transgender, getting gender-affirming care, as well as existing and potentially needed protections related, for example, to receipt of care around HIV. Finally, although there's actually a number of things, other things that I could talk about, but the final big rule that I wanted to mention is Section 504. This is the primary disability non-discrimination regulation that's implemented by HHS. And there was a recent final rule updating Section 504 to provide additional protections from discrimination on the basis of disability. And a handful of courts have ruled that being transgender or gender dysphoria is a condition that is covered from a protected basis from discrimination around disability. I also want to say with regard to administration actions, this is a little bit to the side of everything we've been talking about with regard to access to care, but sexual orientation and gender identity data collection is something that I know many of us think a lot about because we have to tell the stories about who our community members are, what our experiences are, how do we make sure we get access to the benefits, protection, services that we need. So sexual orientation, gender identity, SOGI data collection is a really critical component of that. And this administration has made a number of impressive strides in that direction, including releasing a federal evidence agenda on LGBTQI plus equity, which focuses a lot on data collection. and also making some changes such as the addition of sexual orientation to the HIV case report forms. So the fact that that has taken us quite this long really just speaks to how important it is to continue to have these discussions about who LGBTQI plus community members are and what our experiences in relation to healthcare and in relation to HIV in particular. So there are a number of other resources here. If you want to follow the sort of up to the moment activities, I saw the QR code over there for the Kaiser Family Foundation tracker. There's a number of other blogs and resources here that I encourage you to take a look at to stay abreast of the rapidly changing landscape. But I very much appreciate your time and looking forward to the discussion. Thank you.
Thanks so much, Kellen and Rodrigo, for your inputs, comments, and sharing so much of that information. We're going to switch to a global perspective, which is different and similar. We have one person who's joining us virtually. So I'm going to start with Chris, and Michael's going to end and bring the whole panel to a close before we go to questions. But I'm going to say a couple words. I assume Chris Berer is there. Chris is the director of the Duke Global Health Institute. He's also a professor of medicine there, an MD. There's a lot of things I could say about Chris. I have known him for as long as I've been doing HIV work. For those who work primarily in the global space, although he's done domestic work, he has been one of the leading researchers to document the impact of criminalization laws around the world on HIV programs and outcomes, and also looking at the criminalization of other behaviors or other marginalized populations and key populations. I mean, Chris has just helped develop this incredible body of research that many other researchers are carrying on. And there's a lot more I could say about Chris, but I'm going to turn it over to him, and magically he will be there.
I hope so. Hi, everybody. Can you hear me?
Yes.
Yes. Well, first of all, when Jen and Jesse Milan ask you to do something, always say yes. So I'm delighted to be with you all today. I'm sorry I couldn't be there in person here at Duke. It's also wonderful to be sort of nestled in this wonderful panel between Kellen and Michael, both of whom are friends and colleagues. And I tell you, I was on Kellen Baker's final thesis defense at Hopkins, and I think it's the first time there were ever more than 300 people on an oral exam. He's been a leader in this field really since student days. So what I wanted to share with you and talk a bit about is what I'm calling pushback, and we've published on calling this a pushback, which is really the increase in anti-LGBTQ legislation, but also practices and policies and the impacts that this is having on HIV globally. And I'm sorry to say, there is a lot of resonance, of course, with what you've heard about from the United States, state level, but there also are some very direct connections between what is happening in many parts of the world and the US agenda around this. These are my disclosures, and happy to say that this work is continuing both at Hopkins, where I was before, and now at Duke. So I want to just start by framing this with a couple of key messages, and I think it's really important to understand what the legal landscape is looking like in many countries. So the first thing to say, and I'll show you just a little bit of data about this, is that the evidence base now is very strong, and many people have contributed to building it. That legal sanction or legal protection really have significant outcomes on HIV, and particularly among gay, bisexual, and other men who have sex with men, where a lot of this legislation is aimed. Also among trans persons who have sex with men, and among sex workers of all genders. The data on sex workers is also very compelling, although I'm not going to share it with you. Specifically, the recent waves of anti-LGBTQ legislation are very much focused on a new kind of law, which is variously termed, and I'm using the language in the laws, homosexual propaganda laws. The Russian law is an anti-propaganda law. The new Ugandan law is also in this same group of legal approaches, as is the protection of marriage law in Nigeria, where it was always illegal to be gay, but now where there's been this added level. And what this does, what these laws do, is very specifically criminalize organizing around LGBTQ health and rights, criminalizing support services, criminalizing healthcare provision, and very importantly, criminalizing failure to disclose sexual and gender minority status of patients and clients. So it is deliberately an attempt to reduce healthcare access, this approach. And I think it's very important to say, for example, with the Ugandan law, the language is very broad. This was upheld, that it is a criminal failure to disclose known or suspected homosexuality. So that is about as broad as it gets. And it also, of course, means that people are incredibly vulnerable to things like blackmail, which is very common in these kind of settings, based just on the threat that a supposed or imagined sexual minority or gender minority status could be disclosed. That I think is really critical to understand where these laws are coming from. The language in them, if you can stomach reading these things, is remarkably consistent. And for example, the Uganda, Nigeria, and Russian laws, even though they spread out over close to 10 years now, with Uganda being the most recent, have almost identical language in them. And the reason for that is that they have been drafted with assistance from US evangelicals. And there has been an active evangelical and conservative movement, largely coming from Christian conservatives, although the Ugandan law also had involvement of conservative Catholics from the US. But it's important to understand that we have really been exporting through these channels the policies that have also been obviously influencing state legislatures and influencing religious conservatives in the Congress. And that really matters because these are hard groups to counter. There has been a few estimates of how much, for example, investment is going into these laws and policies. And basically, the LGBTQ rights community is being outspent in general, mostly 5-1 by these evangelical movements. I also want to point out that we can't just think about the legal laws and legal strictures themselves, because there are plenty of places, Tanzania and Kenya very prominently, where it's also illegal to engage in same-sex behavior, but where there haven't been necessarily new laws, but where there's increasing state, police, and vigilante community violence underway, despite there not having been a change in legal standing, although there's a court case from Kenya that I'll talk about at the end. So it's also important to understand that while we often frame our understanding of what is happening globally around LGBTQ plus rights, in fact, many of these laws are very specifically aimed at gay, bi, and other men who have sex with men. And that is because they're so often 18th and 19th century colonial laws are the basis of the discriminations. And women's sexuality at the time was not even considered in general in the law, and of course the whole concept of trans and transgender rights was very nascent. What these laws typically go after, as I'll show you in a moment, is things like sodomy and buggery, and they were very much perceived to be specifically about the sexual behavior of men. But again, I just want to underscore that there are places where there are good legal protections. South Africa, of course, famously the first country to include LGBTQ rights in its founding post-apartheid constitution. But while I was there on sabbatical not too long ago, a leading young youth leader, musician, and activist was murdered in broad daylight in his township. And still no one has been charged with that killing. And it's just important to understand that legal protections are not enough in very homophobic and transphobic environments. So just very quickly, I wanted to share some data on what we have learned about the impact of these laws and policies. And my group at Hopkins has done over the years a number of studies in a number of African countries. Fortunately, and this is epidemiology at its best, I think, using the same sampling frame, so using respondent-driven sampling, which is a proxy population-based sampling for populations who you can't do a population-based sample in, and also collecting data across the same measures, including measures of homophobia, transphobia, and legal sanction, and also doing biological testing with validation so that we can really start to look very directly at the impact of laws and policies on HIV outcomes. And so a brilliant former graduate student, now faculty member at Hopkins, Carrie Lyon, and a large group of our colleagues, including many of the African leaders, Kaletso Makofane and Dauda Diouf and others who have worked with us over the years. What this analysis did was take 10 country surveys with biological testing. Altogether, the largest sample probably there is on men who have sex with men in sub-Saharan Africa, 8,000 or so men. Burkina Faso, Cameroon, Cote d'Ivoire, the Gambia, Guinea-Bissau, Nigeria, Senegal, Eswatini, Rwanda, and Togo. So a very broad range of countries, 25 sites. And this work was done over the 2011 to 2020 period. So what did we find? Well, the key findings here are, first of all, that if you look at criminalization, where is same-sex behavior criminalized, you find HIV rates are 5 times higher compared to settings in which it is not criminalized. So a very direct association between criminalization and HIV burden. If you look at not just where same-sex behavior is criminalized, but where it has been actively prosecuted, we used as a measure prosecution in the last year, then you see this more than doubles. So it's 12 times higher. So the actual implementation of these harmful laws really more than doubles the increased risk association. And finally, we looked at places where these propaganda laws are in place and using as a measure of that, where there are legal barriers to community service organizations providing services and comparing to where those legal barriers were not in place. And it's 10 times higher than among men who have sex with men, where these prosecutions and these limitations on services are being provided. So these laws, which if you read them, for the most part, are focused on the idea that homosexuality can be prevented by making it illegal, which, by the way, there's zero evidence for, actually have very direct effects on increasing HIV burdens in these populations, in these communities. We further then looked at this. This is the same paper. It's from the Lancet last year, and developed what we've called a disparity score. And that is essentially the difference in HIV prevalence between men who have sex with men and other adult men in the same population. So how wide is the disparity for men who have sex with men? Again, it's the same populations. And what you see is that the disparity widens significantly where men who have sex with men are criminalized, 13 times higher. Where there have been recent prosecutions, 18 times higher, which is an extraordinary health disparity. You almost won't see anything like that in public health. And of course, the same issue with restrictions on community service organizations, 16 times higher health disparity. So we think that this is really important, and that disparity index is something we ought to be paying attention to. So I do want to just say that some of those data, of course, are not that recent. The most recent really large-scale sample we have is the Mosaico trial. This is the last HIV vaccine trial. And it involved both cisgender men who have sex with men and trans individuals who have sex with men in a number of countries: Argentina, Brazil, Italy, Mexico, Peru, Spain, Poland, and the United States. Unfortunately, the bad news here, for those of you who know what Kaplan-Meier curves are, is that this vaccine was completely inert. It had no impact, and what you're seeing here is the vaccine and the placebo arms are the same. So unfortunately, it was a failed trial from the perspective of vaccine efficacy. But the incidence, the rate of new infections was over 4 per 100 person years. That is extraordinarily high. And these were people who were all getting a solid package of prevention, including screening and treatment for their bacterial sexually transmitted infections, regular HIV testing and counseling, and, by the way, the offer of PrEP. So all these people were able to access PrEP if they wanted it. And you could stay in this trial if you were on PrEP. So we were very disturbed about that. And I just wanted to share with you that when you look by region, so this is in the lower corner, if you can see my pointer in the middle here, the incidence. In Europe, it was about 1.4. In the US, roughly the same, about 1.3. But for Latin America, close to 5. And that's the same, of course, in vaccine and placebo. That is about as high a rate of HIV transmission as you can get. So we're very concerned. And these data, by the way, are from 2023 up through 24 when this trial was stopped. So it's very, very recent. And we're really very concerned. So we have also taken on the idea that if laws and policies, but particularly laws, are going to be causing such serious health disparities and going to be increasing HIV risks and burdens for our communities, we should take on strategic litigation, take on trying to overturn these laws. And as I said earlier, for the most part, these laws are colonial era sodomy laws. You find them most commonly in the former British and French colonies, but also in other former colonies. And of course, every country in Africa, except Ethiopia, was a European colony, and every country in the Caribbean was a European colony. They all basically, the British colonies all have the same law, and that law is 377A. It's the anti-sodomy statute, and it's very consistent across former British colonies. It's incredibly vague. So, Kellen just spoke to you in a very precise way about the language and the legal issues that we're facing. These are very different because they are between 18th and 19th century statutes, most of them 19th century. And so it's very aged language, and it includes language like buggery, against nature, sex against nature, unnatural acts. And these have generally been aimed at adult men because it was really, or younger men, but basically at cisgender men, because this was the concern at the time, and of course, as I said, women's sexuality was really not much in play. I'm sorry to say that some countries, Malawi, when it was under a former, more conservative government, updated their buggery law to include women, with the realization that, in fact, there was sex of this kind that they're opposed to occurring between women. We have been involved in 6 of these strategic litigation cases. The first one, which was also the first victory, was the first country in the English-speaking Caribbean region to overturn these sodomy laws, and that was Belize. That case was led essentially by one very courageous man, Caleb Orozco, who really is one of those examples of an LGBTQ activist who risked his life and essentially was a one person taking this on. We had a group of Irish pro bono lawyers. The Irish know a lot about overturning British colonial era laws since they were a colony. And then we did the amicus brief. And the argument that we made essentially could be summed up by saying the evidence is that these sodomy laws, these buggery laws are harmful, increase HIV risks and exposures, and that there is a public health argument in addition to a human rights and social justice argument for repeal of these laws. We've subsequently been involved in cases, again, mostly with pro bono Irish law partners in Jamaica, in Kenya, in Singapore, in St. Vincent and the Grenadines, and most recently in Dominica. We have succeeded, these cases have been successful in overturning these laws in Belize and in Dominica. In Singapore, it was a partial victory. They did agree to decriminalize same-sex behavior between consenting adults, but also at the same time passed a law against marriage equality. So a mixed picture. We lost, and I would say there were significant and dangerous losses in Kenya several years ago and in St. Vincent's just a few months ago. And what both of those decisions, those court decisions, had in common was essentially the argument that it was a sort of a turning around of what we were arguing, which was essentially to say, if same-sex behavior between men is associated with higher rates of HIV, then the state has an interest in criminalizing it and maintaining it as a criminal sanction. And the reason for that is, of course, that if same-sex behavior was decriminalized, it would increase, right? So the inherent belief behind that legal system is important to understand. And what it is, of course, is that homosexuality is amenable to change by legal structures, by the police, by social structure. And what we know from all of the science, current science, psychology, human sexuality, is that in fact, sexual orientation is not particularly amenable. It is an innate aspect of the self. And of course, we have recognized that attempts to change sexual orientation, like conversion therapy, are harmful and don't change sexual orientation, but do increase things like suicidal ideation, substance use, depression, and other mental health issues. But nevertheless, that's not where these courts are coming from. And it's not where the evangelicals are coming from. And this, I think, is really critical to understand. Their argument is that LGBTQ people, specifically homosexual men, are out there after your children and they want to convert them to this lifestyle. And we have to criminalize same-sex behavior to protect our children and youth. And that is a popular message in many of the countries where these issues are underway. And it's been a very successful message to increase vigilante violence in Kenya, in Uganda, in Tanzania, certainly in Jamaica. The Jamaica case is pending. We don't know how it's going to go, but I personally, particularly after the St. Vincent loss, which was really a tough one, don't think it's going to go well. But then subsequently, we just had this victory in Dominica and overturned a very harmful anti-gay law. So hope springs eternal. Let me just say that I think we really have to understand how this is operating and who we're up against. And one of the I think really interesting ways to think about this is from a French sociologist who wrote about this now almost 70 years ago. Each nation, by its customs, its laws, its principles of thought, creates for itself a pathology appropriate to itself. A society chooses its diseases and shapes its pathological destiny. And what I would say is that in many of these countries where we are seeing these pushback, this new legislation, and these waves of anti-gay legislation, that these countries, certainly the politicians, the courts, many of the faith-based partners, are choosing a path that leads to greatly increased HIV burdens in sexual and gender minority populations. And those are deadly choices. We have to resist them in every way that we can. And I think as Americans, speaking specifically now to the PACHA, we have to, I think, accept and own that the exporting of these extremely not evidence-based and very biased views of same-sex behavior and sexual orientation are a part of what is happening in so much of the world. And in many, many countries and communities where the LGBT community is profoundly under-resourced and very vulnerable. And I would just make a plea that we think of the LGBT community as a global community, and that we really think about how important solidarity is for all of us across these borders. And I can't think of a better person to hand this off to than Michael Ighodaro, who really is somebody who stands for that global solidarity just every minute of every day. Thank you for your attention.
Thank you so much, Chris. Just Michael, before you start, I just want to say a little bit about you. Michael is the Executive Director of Global Black Gay Men Connect, but he's the inaugural Executive Director of this organization that he helped to found. Prior to that, he was the interim co-executive director at Prevention Access Campaign. He was also worked at AVAC and many other, is involved with many other organizations as an advocate, an activist, a strategizing partner, also his own experience, which I'll let him describe. But I could not think of a better person to sort of close out the panel part of this moment. Thank you.
Thank you, and it's amazing and an honor to be here, and also to be taken over Chris by someone I admire a lot. So thank you. I just wanted to share a little bit more about myself. My name is Michael Ighodaro. I am the founder of Global Black Gay Men Connect and the inaugural executive director of the organization. And we are a membership organization of over 600 organizations around the world focused on Black gay men. We also lead and sort of host Global Black Pride, which is happening in Atlanta this year, which we're all very excited about. So I think I'm not going to go into too much like data or details, but also just like taking back from what Chris discussed specifically, and also just sharing some impact of those laws. And sometimes when we see numbers, we forget that those numbers are people, and those laws impact those people on a daily basis. And so just want to share about like, sometimes also when we hear about anti-LGBTQI laws around the world, we just think it's over there and not here. So we at GBGMC will be doing some data and some analysis of how those laws have direct impact in what we do here in the US. So just specifically, I wanted to share about, Uganda and Tanzania, and also Jamaica and Zambia. I have friends and colleagues specifically who have moved from those countries when laws were signed into law, but also some of them who were not gay or LGBTQI, who just were healthcare providers who had to leave their countries because of fear and persecution, but all actual persecution. And then when they got here, it's a different story. So for me, I got here in 2012 after the AIDS conference, which you all remember. I was, immediately was faced with a very real scenario where I couldn't go back to Nigeria because I presented about my work providing services for gay men living with HIV in Nigeria. I had to seek asylum, so I've been here since 2012. For me, it was an easy process, I would say. It's not the same for a lot of people. I got my asylum less than 6 months after I applied because my case was very public, because the Washington Post did an article about me, and I was attacked in Nigeria, and I couldn't go back to Nigeria based on that fact. Because I also have a global, community, a global village who supported me, who made sure I was able to get asylum. It's not the same for many people. And so they sometimes have to stay 5 to 6 years before they even get to be in the front of a judge. And in those times, they are literally illegal, or they are in a scenario whereby they can't get healthcare, they can't get housing, and they have to depend on friends and family here to support them. So I have friends who had to move from Nigeria, from Jamaica, from Brazil, from Uganda because of laws. And that was 10 years ago. And so now for the first time, they are able to vote in this US election. And it's just not just me. We host a WhatsApp group of over 10,000 people, mostly Africans and Caribbeans who move from their countries, and we provide sort of a network of support for each other. And most of them, for the first time, we call ourselves the first generation of African immigrants who are LGBTQI to leave our countries to come to the US and to seek asylum. And this is our first time of actually voting. And I actually got a vote for my husband for the first time this year, which is exciting, as a US citizen. So just to take back, and two of my friends, one of them lost his wife, he's a healthcare provider in Nigeria, and he had to leave when the law was passed in 2014, and he was arrested and he came to the US and came here, had to wait for 6 years to be in the front of a judge. He had two kids back in Nigeria, and he had a wife, and so they were publicly attacked because of his wife, because of the work that the husband did, and this person is not even gay. And he was attacked and he had to seek asylum. He could not bring his wife here and his kids here because you have to actually get the asylum first before you can get the kid and the wife. While waiting, he also got HIV infected. I can see this guy spoke to him about it. He couldn't get Medicaid because he didn't speak English properly. He couldn't get, he had to, work underground because he never work permit. And so during those 6 years, he had to go through a lot of situations just to get healthcare and get services. This is just one person. And we have several stories in Maryland, especially in Atlanta, in Texas, in across the US, where African immigrants who have moved here from their countries, if they don't speak English, it's a big issue for them. And some of them move here as well. They live within a community of other Africans who are also very homophobic, and they live in a space whereby, religion is a very big thing for Africans. So when you come here, you want to go to a place where you can keep to your religion. And sometimes those religion spaces are led by African churches. And so where they're also very homophobic and transphobic most of the times. So those people are not counted. They are not accounted for. And so what we're trying to do at GBGMC is to sort of find a way to connect those numbers and to show that, a lot of Africans who have moved here 10, 6, 7 years ago are now being part of the impact that we're having right now in the HIV epidemic, but we're not seeing them yet. We're still unable to account for them. So that's just a big deal. Also, just to say, like in Uganda recently, Chris spoke about the law. And so one of the things that are very draconian about that law is like it includes a death penalty. Recently, we fought the Ugandan government sort of, we thought, they wouldn't change the law, but at least they will remove the death penalty, but actually they did not. So in Uganda right now, if you're found to be gay, you have a death penalty on you that you can actually go, you can be stoned to death or hanged to death based on the fact that you're gay. And sometimes these laws are very specific to intersex. And that's what it's about. And in most countries where they have anti-LGBTQI laws, sometimes it's not about the identity. It's about that having two men having intersex. It's just un-African, quote unquote un-African. It's unimaginable. And recently, we work with John Hopkins and others to do like some data around like how many percentage of the country can actually identify as gay or transgender or LGBTQI. And 2% of every country is either gay, transgender, or lesbian. So in Nigeria, we have over 3 million people. Thinking about 2% of 3 million people are LGBTQI, and most of them have no access to care services, and they are being discriminated on a daily basis. Those are just 2% that can openly identify as being part of the LGBT community, and many others cannot. So just wrapping up a little bit to say, like those laws have impacts at home back in those countries, but also have direct relation on what we do here in the US. And there are people who are transgender in Africa, but they couldn't transition. When they come here, they have to find for healthcare. And I have one of my best friends, Noni Salma, who is a filmmaker. She was back in Nigeria. She couldn't go to trans. We all knew she was transgender, obviously, but she couldn't transition as an openly transgender person. She had to have moved here first to transition. I also just to say, like, there are organizations who are supporting this work, who are there and being part of this work, and African Services as well in New York City, GMHC. They are the only organizations across the country who have specific programs for LGBTQ Africans. There are no other way in the country where you have like broader healthcare organizations that have services or specific programs that is targeting LGBTQI population from Africa. So again, as we think about how we work on these issues from a global perspective, we should need to think about the real impacts and how much we are budgeting for programs and who we are budgeting this for. Because also, like you see, most of the times we will go to healthcare centers where we have people that look like us, right? Black people. And so most of those organizations are either underfunded, they're not funded enough to take care of folks like us as well. So we have to drain their budget because they don't have programs to look for, pro bono lawyers or to look for, specific folks who speak the English, the kind of language you speak. So they also have to be burdened. So they don't have that kind of budget. So they are also in real sort of financial issues because they've not budgeted for folks like us. So just to wrap up a little bit to say, at GBGMC, one of the things that we do as well as Global Black Pride is this year, we are hosting a Human Rights and Health Summit. This is the first conference that is specifically focused on Black LGBTQI people that look at the human rights issues, but also other health issues as well. It's happening in the US this time because we think like it's crucial for us to share experiences and bring people around the world together who are Black, who have similar experiences, to share with our siblings here as well, to look at their issues as well, to see how we connect with each other and build the community together. Thank you.
Thank you, Michael. So Michael and Chris have laid the groundwork for us to understand what's happening in the global community, and Kellen and Rodrigo have done a beautiful job doing the same for the domestic. And because the PACHA has a purview that's both global and domestic, we thought this was very important. I just want to add that we did have a trans woman who was scheduled to speak on this panel this morning to ensure diversity, but she was unable. But she informed us early this morning that she was not able to do so. So we wish Araya Lester, who is well known in our community, we hope she feels better and that she does all right. So we've preserved about 15 minutes for dialogue and conversation with the full PACHA, with these incredible specialists. But also we hope that your questions may lead to what PACHA might do with regard to the impact of these laws on any of the epidemic globally and domestically. So we'll start with Carol.
Hi, everyone. Thank you for this great panel. Really insightful. My name is Carol Trest. I'm with the Association of Nurses in AIDS Care. My question really, I think, is primarily for Chris, but anyone who has some insight here, I'd love to hear from you. And in our previous panel, we heard from the State Health Department for the state of North Carolina, who really talked about messaging and how to reach how to move forward even in small steps, right? And how to change your message so that those who are opposed to it can move forward. And so thinking about the impact and what we as PACHA can do, which, but thinking about the role of US-based evangelicals on moving many of these anti-LGBT laws and sentiments forward. Is there any way that you're aware of, or that you can propose that we can move that lever? How can we? Is there a way to influence or stop or limit what US-based and how US-based evangelicals shape foreign policy?
Yeah. Well, I have to harken back some years ago to the first time the Ugandan law was proposed. It was called the Bahati Bill. People will remember President Obama was in the White House, and there was an emergency meeting about this very issue. How are we gonna be able to counter this messaging? Chris Collins was there. I think maybe several other people in the room. And one of the ideas that was put forward was that we really needed an African Christian voice to counter this, exclusionary slice of Christianity, and instead to really speak to inclusion, radical inclusivity, and how important it is to understand that, God's love is universal and nobody's excluded. And the sort of hero of that position was, of course, Archbishop Desmond Tutu. So I reached out to him. I asked him if he would be willing to do this. He was absolutely on it. And we had an op-ed in the Washington Post that was widely picked up across Africa and really went viral. That was just about this message of inclusivity and also embracing the idea that sexual orientation, gender identity is an innate aspect of the self and a sacred aspect of the self. And I think that did really have some play. We missed him when, of course, he's passed when this law resurfaced again. I think what's different and what we have to understand is that the politics have changed as well. And in that earlier period, there was still a great deal of focus, quite rightly, on HIV and on PEPFAR and the U.S. contributions there. And you have to understand, I think, that partly the dynamic is changing. We have other players on the continent, in particular Russia and China, who are very, very active. And the Russians in particular have been really pressing this narrative that working with the West, accepting US dollars means that you have to tolerate homosexuality. And if you side with us, you don't have to. And they've made this a big part of their messaging around Ukraine. And a number of other countries they seek to influence. So we're also up against that pushback. And I have to say, vis-a-vis the administration and the PACHA, I don't have to tell all of you that the uncertainty around PEPFAR reauthorization has not played well for us in these countries, and it makes us look like an uncertain and unstable partner as opposed to kind of a rock solid partner on supporting these countries in their HIV response. So I think the U.S. politics are not favorable for engagement in this area.
Great. We'll try to get to all those who have tents up. So next up will be Phil and then Jeff, and then we'll keep moving. Phil?
Wonderful, thank you. Carol asked the exact question that I was going to ask, so I'm just going to make a quick comment. I just want to thank Jesse and Jen, both of you, for doing this panel. Very educational and important, obviously. So I serve as a physician and help start Open Door Health in Providence, Rhode Island, one of those states that's always progressive and trying to do the right thing. But I just want to make a point that I actually hear these stories from my patients every day, and it does, even what happens in other parts of the country really contributes to what we see in Rhode Island and the burden of mental health as well. Like, these things affect people across the country, no matter where we are. And we even have bills in Rhode Island that are introduced yearly trying to discriminate in our very progressive state. They have no chance of passing, but it takes time and energy to address and to educate and to get up and testify. And, we also have a SHIELD bill this year, which should pass, hopefully. So just want to thank you all for your work and important issue, and we feel it in Rhode Island as well. Thank you.
Jeff?
Another comment as well. Anyone who was at Croy or was watching the proceedings knows that they invited to their open plenary Ugandan activist Frank Mugisha to talk about just the Uganda laws. And, Croy is an international HIV conference. They pay a lot of lip service to the idea of stigma and how it affects, all the stuff we were just talking about earlier. And as he began his remarks, a third of the audience literally got up and walked out of the auditorium. And these are people who were supposed to be supporting these ideas, but they literally voted with their feet and walked out. So, the enemy is not just outside, it's among us. And I think we need to be, mindful of that we're up against a lot. So thank you.
Thank you. Tori and then Mackenzie.
Thank you all. I'm a fan of each. All right, so I'll try and keep it professional. So we all know, everyone in this room knows that the trans community in a very broad sense is so disproportionately impacted by HIV. So how can PACHA, how can the Biden administration, what messages can we take back to really make everyone even more acutely aware of the need for greater research for transmasculine individuals and folks who are gender expansive on the masculine side, masculine of center, and the impact of HIV in transmasculine communities?
Hey, Tori, always good to see you. Yeah, and thank you for that question. Love a question of what can we recommend here? So I've got 1,000 things, but I'll try to just keep it to 3. One, to the part of your question that's specifically about trans men and transmasculine folks. one really concrete thing the federal government especially can do is reschedule testosterone. And this, I don't know how familiar people are with how this works, but when a medication is scheduled, it essentially puts all these barriers up to someone being able to access it. And it's done, if it's done in good faith, it's because of concern about the medication being abused. But in the case of testosterone, this is a very well-studied medication. We understand it really, really well. And physicians prescribe it not only for gender transition in the case of trans men and trans masculine patients, but for all sorts of medical conditions that have nothing to do with gender identity or transitioning. This is a medication we understand really well. There's not risk of abuse in any kind of way that should merit it being at its current status of Schedule 3. So we would really urge this to be really descheduled, but a sort of compromise, a step in that direction would be to gradually reschedule it, hopefully to at least Schedule 5. And this would make a tremendous difference for transgender masculine, trans masculine and trans men patients to be able to stick to medication. We all know that when you have interruption in care, it causes all sorts of problems in your body, let alone feelings of just mentally of being, unsupported by your community. But medically, there are risks in suddenly losing access to medication. And that happens routinely to transgender men on testosterone because of the additional barriers from scheduling. And happy to elaborate on that for anyone who has more questions afterwards. So that would be one thing for trans men patients in particular, is to reschedule testosterone from 3 to 5. Broadly for all transgender people, we'd really urge HHS to zealously enforce Section 1557. That was mentioned earlier, non-discrimination protections. We really need enforcement there. And then lastly, the Indian Health Service in particular, there's something that can be done. The Indian Health Service has a webpage on their website, transgender, but does not say anything about accessing transition-related healthcare in IHS clinics. So if you are someone who's enrolled tribal member, for whatever reason you're using Indian Health Service clinics, and you happen to be transgender, it's very hard to get information about if you can even get the kind of care you need. So if anyone, if you have any connections in the Indian Health Service in particular, yes, thank you. This is a really area of great need for people on reservations, especially.
Excellent. Mackenzie and then Dafina, and we're scheduled to end in 3 minutes. So Mackenzie and Dafina, and let's see where we go.
Wonderful. Thank you so much to all the panelists for being here. And this is great. Thank you, Jesse and Jen, for putting this on. My question has to do with PEPFAR and maybe tagging it with requirements to improve LGBTQI plus policies. I'm certainly not a PEPFAR expert, definitely learning about it as we go. Are there any things that we can do as a nation, or even more specifically to this moment as the PACHA, to perhaps nudge those countries to improve their policies, specifically by maybe making those policy improvements a requirement to receive PEPFAR funds?
Happy to comment on this. I think obviously, as you know, the current PEPFAR ambassador is an African, and he's born and raised in Africa, and he's been engaging with, various countries who are implementing these laws. And sometimes the presidents or the leaders are not, do not want those laws, and it's also very political, and so they cannot really change what they're seeing. But I think the kind of impact that PEPFAR can have right now, they do not have that kind of resources, or maybe like PACHA can push them to have a dedicated program for LGBTQI. And I think the funding right now that they have for LGBTQI issues in key populations, it's less than 1% of their budget. And so again, I think that's where they can have real impact, is increasing their budget and specifically asking them to do more with LGBTQI people.
I was just going to add, because I think this is important from an intervention perspective, the PEPFAR program, since its inception, has always either sometimes publicly, that it's been stated on by the State Department, by the whoever the ambassador was, called out countries in those situations, sometimes not publicly, and have made sure that the funds that they do have are going to the organizations that need them in those cases. I guess a question is, what can be done in the domestic situation like that, but I just wanted to let you know that in addition to what Michael said, there is those efforts within the current budget envelope are already done.
Defina.
Thank you so much. My question is for you, Kellen. I really appreciated you lifting up the maps and showing that one challenge or anti-thing happening tends to be other things happening in those same states. And you also talked about the necessity of leaning on federal protections like 1557. And we see a lot of that happening when it comes to abortion access and access to contraceptives around 1557 and other federal protections. But I would love to hear if you've seen any examples of where we've seen collaborative efforts where we're talking about access to sexual and reproductive health resources, the attacks, facing those attacks on LGBTQ plus IA plus folk. Where are we seeing that work happening in cohesion, where we know that there are multiple things happening in communities that must be addressed?
Yeah, thank you for that question. There are so many parallels here, right? It was never about abortion. It's not really about trans people. It's about an agenda of compliance and control. It's about making other people's personal life decisions, medical decisions for them, and thereby exercising control over their ability to participate in everyday life. So there are definitely folks who are organizing at the intersections of reproductive health, reproductive justice, reproductive rights, and gender justice and trans issues in particular. Thinking about, again, the example of the Women's Research Institute on HIV, where we brought together, we came together with folks who were working on all of these different issues and talked about what does that look like to understand that these are not separate threads. These are actually tightly interwoven and that they have similar and multiplicative effects on things like access to HIV, prevention, treatment, other resources. There are advocacy organizations and organizations that work kind of at the intersection of policy, advocacy, and research. Whitman Walker Institute, the National Center for Transgender Equality. There are a number of other organizations that are coming together around different tables to work on things like messaging. How do we describe what's going on? Acknowledging that there are, again, these parallels between abortion access, for instance, and access to gender affirming care, but also that those things are different in some fundamental ways, like the cadence of how often you need care, how we talk about the role of parents. There are a lot of considerations around messaging that different tables are convening to discuss. There are a lot of efforts to try to take policy pages from the work that's been done around abortion access and apply that in gender affirming care. So for instance, these SHIELD laws, and then there's a lot of community mobilization going on through organizations like Transgender Law Center that are working to say, on the ground, we need to be building coalitions of folks who can demand that we have access to the care that we need, that can reshape the way we think about access to care and services in this country. And it is a real tough uphill battle. But there are a lot of fabulous organizations out there. Rodrigo knows a lot of them. Tori is a member of many of those efforts. Tiomi Luckett from TLC, myself. So happy to talk about in more detail, connecting folks in with some of these messaging, policy, and community organizing efforts.
Great. I think we're getting a 2-minute dispensation from the chairs to wrap up. Is that right? So the last two cards, Hansel, and then the last one up.
Thank you so much, Rodrigo. You make the 305 so proud, and I'm so happy to have you here today. I'm just startled by what Secretary Kinsley said. These laws are very ambiguous. I practice medicine in the state of Florida. I was just wondering, is there any sort of, and this is for you as well, Kellen, is there any sort of practice guideline for healthcare providers and healthcare institutions, a roadmap for how those of us who are in status neutral HIV care provide so much gender affirming care? Is there a roadmap for us for practicing medicine in these very challenging contexts? Because the laws are ambiguous, healthcare systems are afraid. My own healthcare system is afraid and has ended gender affirming surgeries. But I think that providers and healthcare institutions would feel a lot more confidence in continuing to push back if we had a roadmap. Is there anything like that?
Can I suggest we'll take the last question really quickly so that then our panel can wrap it up?
Thank you. It's actually a more of a statement, so it was okay if it stayed to the last.
Just be quick.
But yes, I think for us, longtime fan of Pacha, first time caller, I just wanted to state that for us in the feds, we talk about holding on, letting go, being a balance of life, and I think we need Pacha and other members to help push us because while funding might be level, things we can do in our NOFOs and NOAs, that language can't set precedents for this global perspective because we're all global citizens.
And with regard to your question, thank you for that. One of the initiatives that we do at Whitman Walker Institute is called the Protecting Affirming Care for Trans Youth Coalition, PACT. So it is a network of more than 900 care providers from across the country, and it's intended to be a community of practice. It's also intended to help raise the visibility and expertise of actual experts in the area of healthcare and what it means to be trans and how to make sure that people have the resources they need to thrive. So the PACT Coalition is, as I say, a community of practice around this. So folks ask and answer a lot of questions. We are working on a guide to help folks understand, in particular, the new federal rules, 1557, 504 HIPAA. Obviously, a lot of this will hinge on what happens in November, but it's an excellent flag to think about the role that status neutral HIV providers play in this work. We've been thinking a lot about, to Defina's question, about the relationship with reproductive healthcare, Planned Parenthoods, for example, and how to understand and support them in their role in providing care. So thank you for the flag on working with HIV providers as well.
And I'll just say globally, we worked with AMFAR and IABI to do a best practices for provision of healthcare services to MSM and LGBTQ populations in repressive environments. So I think that's still up on both their websites. So for folks who are thinking about it globally, there are some resources.
Well, we want to thank these experts on what's happening with the laws that impact our community. I know I certainly learned a new term of policy syndemic, and we often think about the broader.
We're gonna make fetch happen.
Right. We often think about the broader Black diaspora that reaches from South Africa to South, Los Angeles, but the LGBTQ diaspora impacts us all. So we want to thank these amazing panelists for their work. Jen?
Yeah, I want to thank everybody for being part of this. It took a lot of time to do this for us, and thanks to PACHA. I don't want to hold us up for the next step, but thanks to everybody.
But thank you.
Thanks.
And as always, Jen and Jesse, thank you for pulling this together. And I do think it really helped to contribute to what has been a powerful morning discussion. We will go ahead and break for 10 minutes. We do have a number of people who have registered for PACHA-to-the-People and are in wait and in queue online. So if I can really ask and encourage PACHA members to return promptly in 10 minutes. By my watch, that would put us right at 12:08. We can get right started. Thank you.
Produced by the U.S. Department of Health and Human Services.